I'm going to just go ahead and get started. Welcome everyone to the Consortium for Workforce Research in Public Health webinar series. We are excited today to be covering two important topics about the public health workforce. The first is recent trends in U.S. government healthcare and behavioral health workforce departures. And the second is Come Work for Us, how to improve the health department job application experience. What is Consortium for Workforce Research in Public Health, or CWORPH? CWORPH is an organization which brings together top research teams from 6 different universities to conduct research in the areas of public health workforce and systems. It is headquartered at the University of Minnesota, and the consortium members also include Columbia University, which is where I am from, Columbia University Mailman School of Public Health, as well as East Tennessee State University, Indiana University, Johns Hopkins, and the University of Washington. We are a HRSA and CDC-funded public health workforce research center, and the only health workforce research center that focuses specifically on the public health workforce. And the work presented today is part of the Public Health Workforce Research Center Year 3 projects. We're going now, this year is year 4, so these are projects from last year. And we are funded by the CDC National Partners Cooperative Agreement to support recruitment and retention in local public health departments. And we have many studies that consortium members have published, including a recent national enumeration of the public health workforce. If you're interested to learn more, visit the website at cworph.org. So for today's webinar, like many others, you can use the Zoom Q&A window to ask questions at any point. And unless there's something really pertinent, we will hold those questions until the end of the presentation. So we'll have the 2 presentations, and then there will be the Q&A period. So do start thinking of your questions. And, you know, again, if a question comes up, which is very apropos of a specific thing someone is presenting, then we may answer that during that time, during that respective session. If you have technical questions, technical issues, that's when you would use the chat feature. Closed captioning is available on this webinar, and the settings can be accessed in the Zoom toolbar on your screen. The slides will be emailed shortly after the meeting to all attendees, and the audio and video of the webinar will be recorded. And a link to the YouTube channel will also be shared in a follow-up email. And we recommend for you to subscribe to our email list to get alerts about additional webinars and projects. And I believe that the link will be posted in the chat in case you are looking to join that email list. And so today we're going to be hearing from about 2 research projects. And the first one is recent trends in U.S. government healthcare and behavioral health workforce departures. And the 2 presenters are Janette Dill, Associate Professor of Health Policy and Management at the University of Minnesota. Dr. Dill is an Associate Professor and Deputy Director of the CWORPH Consortium and Associate Director of Life Course Center at the University of Minnesota. I won't read the entire bio, you can see that. And then Nichole, we are also hearing from Nichole Fusilier. I hope I said your name correctly, and please correct it if I said it wrong. She is a researcher at the Center for Public Health Systems at the University of Minnesota School of Public Health. And Nichole, they are an experienced public health researcher and epidemiologist with a strong background in program evaluation and policy analysis. And their experience includes evaluating public health interventions, analyzing the impact of healthcare policies, and conducting research to support initiatives aimed at improving community health outcomes. And following that presentation, we will be then hearing from Beth Resnick and Paulani to discuss this second project, which is Come Work for Us, how to improve the health department job application experience. And Dr. Resnick is Assistant Dean for Public Health Practice and a practice professor at Johns Hopkins Bloomberg School of Public Health, Department of Health Policy and Management. Her research and practice work focuses on state and local health, public health workforce recruitment, retention, and worker well-being. And Paulani is an assistant practice professor in the Department of Health Policy and Management, also at Johns Hopkins Bloomberg School, and she serves as Associate Director of the school's Office of Public Health Practice and Training. So I'm excited to hear from both of these groups. And I'm going to pause my share and turn it over to Janette and Nichole. And I'm excited to hear from you. Thank you so much.
Thanks, Heather. Right, share my screen. All right. Hi, everyone. Thanks for joining us today. Nichole and I are going to be talking about recent trends in U.S. government healthcare and behavioral health workforce departures. Nichole is actually the first author on this paper, and you're going to be hearing from them shortly. We also have another author on this paper that we want to acknowledge, Elizabeth Stelson, who's at Washington University. All right. So healthcare and behavioral health professionals employed by local, state, and federal governments are integral to the delivery of health services in the United States, spanning community-based prevention programs to large integrated systems of care. Although the effects of federal funding shifts and workforce downsizing have been well documented over the last year, far less is known about how these changes have shaped employment among government-employed healthcare and behavioral health workers. This study addresses that gap by analyzing employment patterns in these workforces over the past decade, with particular attention to emerging shifts in 2025. Although the U.S. healthcare system is largely privatized, thousands of health professionals are employed directly as government workers, many providing critical services that are often overlooked. For example, over 300,000 workers in the federal workforce are in healthcare occupations. Many additional thousands of healthcare and behavioral health workers are employed by state and local governments. These workers include public health nurses, health educators, and behavioral health specialists who provide care in public hospitals, county health departments, and state-run mental health facilities. Examples of large county-run safety net hospitals that employ thousands of healthcare and behavioral health workers include Los Angeles County plus USC Medical Center, one of the largest public hospitals in the country, operated by the Los Angeles County Department of Health Services, Cook County Health, which includes the John H. Stroger Junior Hospital and Provident Hospital, both operated by Cook County to serve residents regardless of their ability to pay. And here in Minnesota, we have Hennepin County Medical Center, which is located just down the street in Minneapolis. The Philadelphia Department of Public Health operates 8 primary care clinics across the city. And then there are many examples of state-run hospitals, which include University Hospital, which is operated by the state of New Jersey and serves as the principal teaching hospital for Rutgers, New Jersey Medical School, and Central State Hospital, a state-operated psychiatric facility run by the Virginia Department of Behavioral Health and Developmental Services. State agencies also often deploy social workers and mental health counselors in community-based programs, such as South Carolina's initiative that recently doubled the number of counselors based in schools. At the federal level, important government-operated systems like the Veterans Health Administration, or the VA, and the Indian Health Services, IHS, employ tens of thousands of healthcare and behavioral health professionals. The VA, the nation's largest integrated health system, serves more than 8 million veterans annually. Similarly, IHS operates facilities across 35 states to serve over 2 million American Indian and Alaskan Native people, employing clinicians such as nurses, psychiatrists, social workers, and substance abuse disorder counselors to address both physical and behavioral health needs. Recent federal budget reductions and administrative restructuring, however, have disrupted these workforces. Federal health systems, including the VA and HIS, have also experienced funding cuts and staff layoffs. Between January and June 2025, the VA lost nearly 17,000 employees. Given staffing shortages already reported within the VA, further staff eliminations could compromise quality of care and exacerbate long wait times. Similarly, the IHS continues to face chronic vacancy rates of around 30%, with proposed layoffs generating strong opposition from tribal leaders concerned about diminished access to essential services. So, despite media attention to selected programmatic or agency level impacts, less is known about how these policy changes are influencing the overall workforce trends across government, healthcare, and behavioral health sectors. So, to address this gap, we analyzed data from the longitudinal panel of the current population survey, IPUMS CPS, to assess exits from government employment among healthcare and behavioral health workers between 2015 and 2025. Using 10-month cohorts from October to July, we examined two outcomes. The first is exits from government employment with continued labor force participation, so indicating transition to a non-governmental role. And the second is exits from the labor force entirely.
All righty, thanks, Janette. So to talk a little bit more about our study design, I'm going to talk about the data set source. So like Janette said, we use the longitudinal panel within the current population survey, or the CPS. So that is a monthly household survey. And so when households are selected into the sample, data is collected from them for a total of 8 months. The household members are interviewed for 4 consecutive months. Then they're left alone for the following 8 months. And then they're interviewed again for the next 4 consecutive months. So in total, the panel is 16 months long, but data-wise, we have those 8 observation months that we can use for analysis. And so these month-to-month observations allow us to follow those employment transitions for the individuals in the panel. And so, like Janette said, our observations span from 2015 through 2025. All right, so let's talk about how we built our sample. So in addition to demographic data, the current population survey collects information related to employment status, workforce industry, and occupation type. And that's what we use to define our sample. So we included adults over the age of 18 who were employed as local, state, or federal government workers. And they were also working in healthcare or behavioral health occupations during the survey period. And so those healthcare and behavioral health occupations are identified in the US Census codes. So that's how we made those groups. So we constructed a 10-month observation cohorts that span from October through July for each year from 2025 or 2015 to 2025. And so each cohort was designed to begin in October, the month preceding a presidential election, to measure those job transitions occurring in November following the election. And then the cohorts ended in July just to align with the most recent data we had available from CPS at the time of our analysis. So from October, from 1 year through July to the next year would be one cohort. And we had 10 of those cohorts. Right. So we had two primary outcome variables. So that first one is where we measured whether an individual transitioned from government employment to non-government employment. And so exits from government employment were identified when an individual reported working in a government setting during the previous month, but not in the current month. So for instance, if in month one, they were working as a local government employee in a healthcare occupation. And then the next month, they were no longer listed as working in local government or any kind of government, any level of government at all, then that would be considered a transition to non-government employment. Our second outcome variable was whether an individual, again, employed as a government healthcare or behavioral health worker, if they just exited the labor market entirely. So either they were unemployed or had chosen to not be employed, so just not in the labor force. Next. All right. So for our analytic approach, we use logistic regression models to estimate the likelihood of an individual leaving government employment or exiting the workforce, those two outcomes. Each model accounted for several demographic characteristics and contextual factors like race and ethnicity, gender, education, residence, and so on. After that, we then calculated the probability that an individual would leave government employment or exit the workforce. And we stratified this by the government level and the occupation category, which I'll talk about in our results. Also, by dividing the sample into cohorts, we could observe any trends that occurred over the years. All right, so with our sample, it included just over 8,000 behavioral health workers and then 17,000 healthcare workers, again, who worked in local, state, and federal government. And so in the table that we have here, we see that most of the workers in the sample were employed by state government in both the behavioral health occupations and the healthcare occupations. But we do see that federal employment was more common in healthcare workers compared to the behavioral health workers. And then local government employment was more common in the behavioral health group compared to the healthcare workers. All right, so here we have this figure. And so this figure just illustrates the trends in the predicted probability of workforce exits and transitions among our governmental healthcare and behavioral health workers in our 10-month cohorts. And in this figure, it is broken out by the level of government. So we have local, state, and federal government. So there are two sets of lines in this figure. We have the dashed lines, which represent transitions out of government employment, and then the solid lines represent just exiting the workforce. So first talking about the dashed lines in the graph. So across the survey period, local government workers consistently had the highest likelihood of leaving government employment. Their probabilities were typically between 8 and 9%, and this was followed closely by state workers. Federal workers, so the federal government workers, had lower probabilities of leaving government until we start seeing a sharp increase in that most recent cohort, which brought their rate closer to 8%, which matches the state and local levels. So overall, they've been lower, but we see this uptick in the most recent cohort. So moving down to the solid lines on the graph. So that again is the probabilities of exiting the workforce. So these were lower overall, but they were relatively similar within each level of government. The healthcare workers and behavioral workers in local government had probabilities around 3.5 to 4%, and then state workers followed behind them pretty closely with the same trends. Federal workers consistently have the lowest rates of labor force exit, again, until we see an uptick in the most recent cohort at the very end of the graph there. And so ultimately, all of this together suggests that while local and state employees are generally more likely to transition out of government or the workforce altogether, the federal employees have experienced a late but notable uptick toward higher exits and transitions in the most recent years of observation. All right, so here we have a similar figure, but this time the probabilities are broken out by our two occupation groups. We have healthcare workers in purple, behavioral health workers in blue, and then the same setup of the dashed lines represent the transitions just out of government employment, and the solid lines represent exiting the workforce. So again, talking about the transitions out of government employment, we see that healthcare workers consistently showed higher probabilities of leaving government employment compared to the behavioral health workers. The probability for healthcare workers ranged between 8 to 9% over the years, with a couple of peaks and valleys. We can see a notable peak in 2021 that then it has a slight decline, but we see again it's starting to tick upward in the later years in 2023 and 2024 cohorts. Um, when we look at the behavioral health workers, we see that we have a more stable pattern, but we do again see, instead of an increase in 2021, we see a dip in this group in 2021. Uh, so then when we move down to the solid line, so looking at exits out of the workforce altogether, again, we see that those probabilities are lower overall. For healthcare workers, they range between 3.5 and 4.5%. And then behavioral health workers were generally a little bit lower than that. And then we do see that for both groups that there is a slight uptick in the exits in the 2024 cohort. So again, with the most recent years. So overall, we see that healthcare workers employed in our government settings have been consistently more likely to leave government positions or exit the workforce altogether compared to the behavioral health workers. But altogether, we see that there is a slight uptick for both groups in the most recent years. And so with that, I will hand it back to Janette to close us out.
Right. So our study is we're going to claim that it's the first to evaluate employment trends in the government healthcare and behavioral health workforce that extends through 2025, a time in which substantial changes, there have been substantial changes in federal funding and social policies and layoffs that are defining the healthcare and behavioral health landscape in the U.S. With this population-based survey with the CPS, it allows us to follow participants over the course of 16 months and contains detailed occupation and industry codes, which allows us to identify a sample of government healthcare and behavioral health workers and to examine their employment over time. And the rapid availability of CPS data additionally allows us to observe these very recent trends. That said, this study does have several limitations which are important to consider. First, the occupation and industry codes in the CPS can lack precision, although they're pretty good for the healthcare and behavioral health workforce. While we believe we identified the vast majority of healthcare and behavioral health government workers, measurement of error, of course, is always still possible. We were also only able to observe trends through July 2025 at the time we were doing this analysis. And so, future research can certainly build on this analysis and continue to look at workforce departures using more recent data. And then last, it's important to note that the CPS doesn't provide data on the reasons participants chose to transition out of their jobs. It does provide some data about whether or not a person is choosing to retire or stay home with family, etc. We didn't dig into those reasons, but for personal reasons, we don't really know. So, people respond to large social, political, and economic forces such as COVID-19 pandemic and the reductions in federal investments for they respond in many different ways, but we don't know personal reasons for exits, which likely intersect with professional reasons and may contribute to these trends. All right, so let's talk briefly about some policy implications. Healthcare and behavioral health services are largely privatized in the US, and likely for this reason, literature on these workforces employed by the government is pretty thin. While the exact size of the government healthcare and behavioral health workforce across federal, state, and local settings is unknown, it is considerable and provides essential services to veterans, indigenous communities, and people needing access to the limited safety net services provided within the U.S. healthcare system. As I said earlier, over 300,000 federal workers are employed in healthcare occupations, and many more work in state-run facilities and county health clinics, among other settings. All right, as such, the trends in workforce reductions we identify in this study carry significant implications for service delivery and public health capacity. One issue that's currently contributing to job instability and job loss among government healthcare and behavioral health workers is cuts to Medicaid. The Harvard School of Business or the Harvard School of Public Health Healthcare Quality and Outcomes Lab analyzed how major federal Medicaid spending cuts under the 2025 One Big Beautiful Bill Act are likely to strain the financial health of U.S. hospitals, especially urban safety net hospitals that serve large numbers of low-income and Medicaid patients. The analysis found that of the small subset of hospitals facing the greatest vulnerability, those that are safety net providers, already financially distressed, and with a high Medicaid patient share, almost 85% are in urban areas. because the cuts will reduce Medicaid reimbursements, increase uncompensated care by expanding the uninsured population, and eliminate state revenue strategies like provider taxes. Many urban safety net hospitals could face severe budget cuts, risking service reductions, closures, or bankruptcies. While the Rural Health Transformation Program may provide relief for rural safety net hospitals, urban safety net hospitals especially, and the workforce within those hospitals are at significant risk. Okay. It's an uplifting presentation. I think we will take questions after the next presentation, but please be thinking of the areas where we could provide clarification and further discussion.
Thank you so much, Janette and Nichole. That was fantastic. And I have so many so many questions. Thank you so much. And now, Beth and Paulani, please take it away with your presentation. Thank you so much.
Thank you, Heather. Thanks, Janette and Nichole. What we're going to present on is a little different but related, is about our study on Come Work With Us, how to improve the health department application experience. So just to give you a little background and sort of connect with the presentation we just heard, we focused on state and local health department hiring. And also we did not separate out any different positions in terms of healthcare or behavioral health workers, which we just heard about. Ours was just about their employee, the application experience overall for any employee. So just a general background, which I assume everybody is sort of aware of, but just to set sort of where we're starting from, is we looked at job application processes and strategies that they could improve recruitment in state and local health departments. And it builds on our year 2 work in CWORPH to look at innovative workforce development strategies and also, partnerships. And then also, we already just heard about this in the first my mouse is a little jumpy. We just heard about this in the first presentation, but I just want to highlight something that I think is important. Given what's happened in the federal government and then the resulting labor market shifts and things, some state and local health departments, again, probably varies depending on where they're located and sort of their current status, might have some things happening differently now. Maybe recruitment is easier, or maybe less people are leaving given the changing labor market. But we actually think that this was short term, and originally we had talked about maybe doing cross-industry hiring to see how does health departments compare with the rest of the labor force. But given all of this, we just decided here to think about sustainable process improvements, and we'll talk about this more at the end. And in particular, what we would really like to engage with this audience about is what are some sustainable things that can be changed, even given all of the other changing forces that we don't have control over. So that's sort of our aim, to look at what are some control levers that people could do even now, even in the context of whatever's happening in your state budgets or local contexts. So I'm going to turn it over to Paulani to give you a little more detail about our study and share some of the findings.
Thanks, Beth. So in terms of study design, we structured this as a cross-sectional study with 2 main components. Specifically, we conducted qualitative, semi-structured interviews with state and local health department employees on the job application and hiring process, and then conducted a supplemental observational scan of publicly accessible state health department job application portals across all 50 states, as well as DC, to gain additional insight into the job application experience, in particular looking at the clarity of available job listings, as well as ease of navigation within those application portals. And we chose to focus our scan on state agencies to really enhance comparability across sites and also limit variability in structure, resources, and hiring systems. Our team then conducted qualitative analysis and thematic coding of the interview findings to identify key themes and insights, and then triangulated these with our observations from the application portal scan to identify strategies for improvement. A little more about our qualitative interviews. So recruitment for the interviews was conducted utilizing existing workforce connections that our team had with governmental public health agencies, in addition to snowball sampling to recruit additional individuals at other agencies that met our eligibility criteria. And our interviewees fell into one of two main groups: recent hires at state and local health departments, defined as those who were hired and onboarded within the past year, as well as state and local hiring managers and human resources personnel. And in total, we interviewed 16 individuals representing 4 states and 6 localities across all 4 regions of the United States. Across our qualitative interviews, there were 3 key themes that emerged in terms of recruitment and hiring challenges. And the first focused on structural factors, particularly navigating bureaucratic hiring processes. The second was more focused on market dynamics and the importance of maintaining a competitive advantage, while the third centered more on work culture and the need to balance flexibility with accountability. So we'll walk through each of these in a bit more detail in the next few slides, but at a high level, these themes really show that recruitment and hiring challenges operate at multiple levels that, while distinct, also are interconnected. So let's start with the first theme on navigating bureaucratic hiring processes. So a common challenge that was shared by our interviewees was that hiring processes are cumbersome and lengthy and often unclear and fragmented. And so one state employee we spoke with actually shared that it took them 3 years to hire and onboard a staff member from the date of when that position was created all the way to when that staff member actually began working. And additionally, since teams aren't necessarily hiring new staff on a regular basis, it can also take time for hiring managers to relearn and refamiliarize themselves with the entire process every time they have to hire someone. Administrative barriers and lengthy approval processes are also a challenge, particularly for those who have to navigate multiple levels of approval to even be able to post a position or offer a specific salary or classification. And as you can see from the first quote on the slide, oftentimes by the time they already have obtained all the necessary approvals and get around to actually offering a position, candidates have already taken other jobs and they have to start the process all over. And as another interviewee noted in the second quote that's shown here, hiring staff are tired, not just of the workload, but of the system. So to combat some of these challenges, some of the interviewees that we spoke with have turned to internal hiring workarounds to really get staff in the door more quickly. So one example is an 89-day hire where an employee is brought on for up to 89 days. And so this is typically used to meet more short-term staffing needs. The role is capped below 90 days to maintain a temporary classification, but just to note, like as you can see from the quote on the slide, the downside of the 89-day hire is that the person doesn't get any benefits or service time. So they're not getting health insurance, vacation, or sick leave. On the flip side, you're getting them in the door more quickly and they're able to actually start the work faster. And so, for example, in some cases where there might be a strong applicant where they want them to get in and get started sooner, we heard that hiring managers sometimes will pursue an 89-day hire while simultaneously also working the applicant through the full hiring process on the back end. Another strategy is also to use temporary or contract hires, as there are typically fewer steps to get these hires through, and there's also a bit more flexibility in terms of salary and benefits, given that these are non-merit positions. And something else I wanted to note, which is not on this slide, but this was unique to one of the states that we spoke with, was actually to consider taking a legislative approach to modifying hiring rules or processes. So the particular state that we spoke with, this might not be possible in all states, but they basically passed a bill establishing a pilot program to relax minimum qualification requirements for certain entry-level roles and also shift more of their applicant screening authority and responsibilities away from their centralized state HR office to the department itself, with the goal to expand their applicant pool and speed up hiring. So that was another strategy that one state had used. The second theme was around maintaining competitive advantage in the labor market. So health departments often can't match salaries that are offered by hospitals and the private sector, and particularly for clinical positions and specialized staff. And this is especially difficult for public health nursing roles, as these were repeatedly cited as roles that were hard to fill. You can see this from the top quote on the slide. Nursing is a challenge for us because we're situated between to larger urban, more competitively salaried areas, particularly since COVID when the salaries went up so dramatically, and then leadership positions for pretty much the same reason. At the same time, we also heard anecdotally that new nursing graduates often prefer hospital settings where salaries are higher, and then more experienced nurses often can find governmental work environments less appealing. Agencies also operate within rigid pay scales and classification systems with limited ability to negotiate salary. And the second quote on the slide speaks to this particular challenge, where they're discussing the limitations faced in order to hire into range, as they need to get talent to come in at the lowest cost to the state, which means bringing in candidates at the lowest possible step in pay scale unless they can justify otherwise. And this makes it challenging to compete with employers who can move more quickly or offer higher salaries. And our interviewees also shared how broader funding and resource limitations impact salary offers as well as hiring flexibility. And so in some cases, regional pay parity rules can also create additional complications. So for example, if one jurisdiction wants to offer a higher salary to their staff, that could potentially trigger mandatory pay increases for staff in neighboring counties, which might not be supported by the budget. And additionally, there also can be tensions across state and local agencies as well. So one example we heard was when state agencies recruit and hire staff directly from local health departments after those departments have already invested time in training them. And lastly, there was also emphasis on how remote and hybrid work has transformed recruitment dynamics, with some employees leaving for positions that offer more flexibility, and agencies also having to increasingly compete with employers who can recruit more nationally for remote roles. In terms of ways to maintain competitive advantage, the strategies shared really centered around intentional communication with applicants. So because health departments often have limited flexibility on salary, several interviewees emphasized the importance of really clearly communicating the value of the work and the broader benefits of the role. And that includes highlighting the public health mission and the opportunity for that applicant to be able to contribute to community impact. And this is evident in the quote on the right, where it says, "We talk about the mission serving our county, and that resonates even if the pay is lower." And additionally, another strategy to motivate applicants and remain competitive is also to ensure that job postings clearly describe and highlight non-salary or non-traditional benefits. And those can include things like tuition remission, loan repayment, professional development opportunities, supportive workplace policies, and hybrid or remote work options. And this is reflected in the quote on the left, which is from a recent hire that we spoke with, who noted, "I live in the adjacent county, and one of the things that appeals about the job, and quite honestly, the only reason why it's feasible, is it's a hybrid position." As a whole, showing applicants the full value of the role beyond just salary can help agencies better attract and compete for strong candidates. I'm now going to turn it back to Beth to take things from here.
Thanks, Paulani. So last, I'm going to just talk a little bit about this point that we were saying about balancing flexibility and accountability. So what do we mean by that? It's a little bit hard to explain, but basically a lot of it was around the remote or the hybrid work, or whether you can or cannot have that. And so it's sort of I think this one aligns somewhat with the competitive advantage issue too. So what we heard from our interviewees was that the importance about setting clear expectations about available options for flexible work early in the application process. So again, you don't want to go through a whole process and then you get to the end and the applicant thinks, oh, I can work 3 days from home and they can't, or vice versa, right? So again, having clarity about that. And when I get to the application portal findings, it sort of aligns with that, being upfront about what's available, what's not, or what might change, or how things, where there might be options or opportunities. And again, as Paulani already said, in the competitive advantage, emphasizing available benefits, resources, and supports. So again, these quotes, and I think again shows where maybe we can get a little creative, right? So someone was talking about that they allowed their nurses to work 4 10-hour days and then have 1 day off. Or again, giving them the option, maybe they could work from home every other week to do the paperwork or the reporting, that they wouldn't necessarily need to be in the office. And then this last one on the left, again, a little more creative thinking and changing how maybe traditionally we've done things. that they had a children in the workforce guideline to help new parents easing back in, and also juggling a newborn. Again, context is going to be important here, and how that would be rolled out and implemented would be important. But these were two examples that people shared of things that were able to be balanced. Okay, so now we're switching a little. This is the job application portals. As Paulani had shared, we had looked at all 50 states and DC, an informal scan of the application portals when you're applying for the job. And basically a key finding we found across almost all of them, maybe there would have been a few exceptions, but that the portals really did lack a user-centered design focus. Again, a lot of these were more set up for the government functionality to get the information, as opposed to really thinking about a user-centered design. So the navigation of the portals, we found that there was a very wide range. If any of you have been on any of these, you're probably not going to be surprised in the ability to search and filter, whether you're able to do that at all and what functionality there is, as well as clicking through to be able to actually access the jobs in terms of how many times you would have to click through or how easy it is to navigate that. And then around the job descriptions, again, we saw a large range of clarity and specificity of the duties and responsibilities. Again, maybe many of you are aware, sometimes they might have a generic like health policy analyst 1 position, and they just use a standard job description. There's no specifics about what division or what type of position it might be. And again, that's very hard for the applicant to then navigate whether they're interested in that or not, or whether they're qualified. There is very inconsistent guidance on application processes and hiring timelines. Working in a grad school and having many students trying to find jobs, this is really frustrating to applicants, right? They don't know what they're supposed to do, when they would find out. As people are looking for new jobs, if they're currently not employed, they have expenses, they need to know, when would I hear back? And as Paulani had shared, the 3-year time frame, that's just not going to work for people that aren't currently employed and need a position. Also limited information. Again, this is about the remote work things, professional development opportunities, trainings, if there's anything like tuition repayment, loan repayments, things like that. Making that available and clear right in the job description is really helpful to give applicants more information about the job up front. It also then will save you time on the back end, because if you are interviewing somebody who's really not a fit, then giving them knowledge about that upfront. Actually, we didn't write in here, but I think we have it in our other information. Salary also. So again, so that you're hitting the right people at the beginning of the process, saving everybody time. So what we came up with our strategies that, again, through both our interviews, triangulating the interviews and looking at the portals, was optimizing these portals as much as they can to improve navigation, tailoring the job descriptions, again, as way I just shared, with specifically about what that job is and what the duties are. Again, when you think about a mission-driven organization, if the position's in maternal and child health versus environmental health, right, those are hugely different. So even if it's the same classification, having specifics around what the job is. As I just said, including the hiring process steps, and again, they might not know for sure the full timeline, but at least an anticipated timeline, or even a basic, you will hear back from us within 2 weeks, or, and then we'll go to a next interview if you hear back, so again, a timeline thing to lead, so you're not leaving people hanging. Using supplemental application questions to enable applicants to, again, better emphasize their relevant qualifications and experiences that can help on the selection team, and also allow applicants a better sense of what these jobs are and what they're applying for. And then lastly, including something like, here's our ideal candidate profile, again, to help applicants better target jobs. And I know nobody wants to do this because you don't want to get a zillion questions, but if you can include a recruiter or hiring manager, contact information, so again, they can ask some questions and kind of know what's going on. This can also be super helpful if you have applicants that are applying for multiple positions and they actually really want the state local position, and then they get another offer, like again, having somebody that they could contact to kind of talk through it with could actually help save opportunities maybe for people who actually really would want to work in government but are confused and don't have information, so they don't know. So limitations of our study, this was cross-sectional, again, just in the moment of time. And again, with the changing labor market and all of the things that have happened over the last year, that is important because things are rapidly changing. This was random. It was not intentional, just based on our contacts and who was able to do the interviews. We happen to have a primarily decentralized department, so the local health departments were operating independently. So the findings and their strategies might be a little less applicable to others that might be centralized or have greater state oversight of the hiring. And again, of course, given the changing landscape right now and budgets and changing times and politics pieces, you know, some of these might not necessarily be generalizable, but we do think the majority of our findings were hopefully pretty relevant to all departments and in terms of our final takeaways. And I really want to highlight this, especially in this changing labor market. What we are really trying to do is look for department controlled levers that they could strengthen their recruitment, even if they're facing some structural and budgetary constraints right now. We do, when you think about it in the larger picture, the recruitment challenges really do reflect both technical barriers in terms of slower approval processes, rigid classifications, the portal design, and then also adaptive tensions where maybe they can intervene in terms of flexibility in the work schedule or workplace. Accountability, so even if someone's not on site, is there systems in place that you could make sure that the work is getting done that needs to be getting done, and again, having an organizational culture where you're more transparent and communicate in the jobs in terms of benefits and opportunities. And again, in the same vein, when compensation structures are constrained, departments can control possibly the communication with their applicants, transparency in how much they're sharing, and again, clarity. I cannot stress this enough, clarity throughout the hiring process. This is also one area, again, it wasn't in our research because we did not do cross-industry, that I don't think anybody is a superstar in this, even in the private sector. So again, little bits of helpful information and helping the applicant along the way can make a big difference in terms of creating a culture where people feel like they're wanted and valued right from the get-go when they're starting their application. And being clear on, on the job mission specifically, the mission of your health department, sort of connecting them into the mission of your department, the responsibilities of what they're going to need to do in the job, and the hiring process. And again, being very clear on flexible work scheduling, if it's available, if it's not, again, because that's something that is really important to people now, and it really has changed the dynamics of the work environment, particularly for younger workers who are coming in with different expectations around that, and what their norms are in terms of how work is done has really changed in the post-COVID era. So that is all we have. We'd be happy to take questions, either if people, Heather has some, I know, probably people in the audience, or if you want to put it in the Q&A. We look forward to some discussion. Thank you.
Thank you all so much. That was fantastic. Super interesting. I'm not sure if anyone who is, in the webinar audience found some of these findings validating. If you have been a job seeker at some point in the last while, or are working in governmental health one way or another. I didn't really introduce myself at the beginning of the webinar, but in addition to being a researcher for the Consortium for Workforce Research in Public Health, I also am the Associate Dean of Career and Professional Development at Columbia University Mailman School of Public Health. And so I do also see, like Beth mentioned, sort of this bigger picture view in terms of observing how the local or state health departments do recruitment versus, for example, private sector industries that might come on campus, and how their presentation might be structured and things like that. So you can kind of compare and contrast the private sector and the other sectors of recruiting. So I would love to let folks in the group ask a question. So you can just type your question into the Q&A box. I don't see any questions right off the bat. So I do have a few questions for both groups, both presenting groups. Um, I would love to start with Janette and Nichole. If you can share a little bit about where do you think that workers in your sample go if they're no longer employed in government jobs? I don't know if there's a way for you to see what they went to do next. Um, and this gets into the competition, which Beth and Paulani are also talking about, is who else might be hiring these folks. So Janette or Nichole, do you have a flavor of where people go if they're leaving government? Any ideas there?
Nichole, do you want to jump in, or I'm happy to give my thoughts too.
Yeah. So as far as what's reported in the data, we can't really capture it as well. Just because I'm thinking of it correctly. I think the only other options that we get in that particular like class of worker variable is just like private or self-employed. So we really don't get an idea of where they're going. I think if we wanted to, we would possibly maybe look at industry to get a better idea of like, okay, where are they going kind of setting wise? But we can't really nail it down in the data exactly.
Okay.
I'll just add that so we know for most of our workers, they stay in the labor force. They're just switching out of government roles. So it's very likely they're going into, clinical settings that are just not government clinical settings. So they're probably going to, nonprofit or for profit healthcare setting and working there. For the workers who leave the labor market, it is that includes people who are retiring. And we do know that retirement is very sensitive to funding disruptions and to other disruptions in the labor market. So during COVID, we saw a bunch of early retirements. It is possible now that we're also seeing some early retirements as people, react to funding situations or instability in the workforce.
It's interesting. So I'm just going to mention an observation from one of my research projects that was a couple of years ago, which looked at salary disparities for people in the same job occupations who worked in local or state government versus um, basically all the other sectors.
Mm-hmm.
And it's generally true that the salaries tend to be lower, and for certain occupations they're really a lot lower. Like epidemiologists can make a lot more money in some
Mm-hmm.
cases. In other sectors, certainly computer occupations and programmers, things like that. But what's interesting is that some of the mental health related occupations, like social workers and mental health counselors, often earned more in
Mm-hmm.
government. And that
Yeah.
may be because the competition is maybe small community-based nonprofits and things that actually pay less than government. And I'm curious if you think that might explain a little bit about why you saw in 21, 22 this increase in the healthcare workers leaving government because probably they could be paid a lot more as a travel nurse at the local hospital or whatever during COVID, where the behavioral health workers stuck around, it seems,
Mm-hmm.
at least during the COVID time. And then they
Mm-hmm.
started to leave later. And I'm hypothesizing maybe the kids came back to schools or something like that, and behavioral issues came up and it was harder work to do, after COVID
Mm-hmm.
didn't really end, but when the pandemic emergency was. I'm just curious what you think could explain why you saw healthcare workers leaving, but behavioral health folks sticking around during COVID. That's just my hypothesis.
Yeah.
I don't know if there's a way to know.
Yeah, we have found the same thing in our research that behavioral health jobs are better in government and they are worse outside of government, which is different than many other patterns that we see across different occupations. And so, um, yes, I think behavioral health workers are more likely to stay in their government job because compared to the private sector, government health care or government behavioral health jobs are paying more, they have better benefits. So they're just more stable. Yeah.
Beth, what did you, yeah, I know this intersects with the retention and recruitment part also, because you can't pay the comparable wages. That's a huge barrier to recruitment and retention. Go ahead.
Yeah, I was just going to add, and now this is purely anecdotal because I have not done research specifically to the behavioral health workforce, but it's at least from the behavioral health providers that I personally know, that the remote piece has also transformed that field, and many of them now can work fully remote and do all of their meetings virtually. So
Yeah.
I know several social workers that are clinical social workers that are doing that now. So again, I think that also their opportunities probably really changed post-pandemic in the mental and behavioral health field.
Yeah. Yeah. You can imagine a healthcare worker in a safety net hospital during the pandemic, right? Like that was a very dangerous job. Behavioral health, less likely, be,
Yeah.
because of the remote option.
But I do want to highlight, and I know we talked a bit about this. I said we could do a whole webinar on remote work and hybrid work because again, the changing expectations. But and I think some of our colleagues in our center have also highlighted this, the huge impact that can have on rural areas, because it's really hard. Now you have open remote options, so then the few workers you might have had now can take other positions where you're getting paid a lot more. So, you're doing behavioral health work in New York City, but you're living in, someplace that is a lot less expensive. So again, it's really uprooted the whole thing. And I think we, as our center, really need to think about the impacts of that and who might be disproportionately impacted by a lot of this shifting.
Yeah.
So we only have 3 more minutes. And again, if anyone has questions, please don't be shy. Put them in the Q&A if you want. I was going to go back to Beth and Paulani again. I do want to say at one point I worked on another project which had to do with developing a training for people who want to apply for jobs in local and state government health departments. And I will just put that in the Q&A for people, or we can see if there's a way that could be shared also. But as part of that project, I had to look at all 50 state hiring portals. And so I'm just curious if you observed anything that might be improved in the short term with those many online portals. They're like the bane of everyone's existence who is actually applying for jobs. So what are your
Yeah.
thoughts?
And yeah, God bless you, Heather. You have done so much work in this area. You probably have more knowledge than we do. But I do think with kind of what we put in our recommendations in terms of even if the portal is clunky, having better, and you already did a project on this, I know, because you had job descriptions, right? So where you can include some different, and I understand there's sometimes constraints because they just have to post up by job class and they can't post for individual positions. But my example that I think is very relevant is, somebody working in MCH versus somebody who might be doing some elderly aging populations, right? Those are extremely different jobs. And even if they're the same class, so again, having more information, and even if it's a supplemental application process, so you could still use that same, being creative, right? So you could use the same standard job description, but then have a supplemental thing that would have more information. And in terms of teaching a class for the applicants, I think it's really patience and persistence, right? And again, if you can find somebody to connect with, which is why we were saying put a contact info number in. And I know we're running out of time, so I don't want to keep on going. But again, there's lots of things, small things that people could do to make it a little better.
Absolutely. Well, thank you everyone for your presentations. I really do feel like we could keep going on and I could keep asking more questions. And someone had an additional question, which we'll try to pass that along for later. Please do join us for our next webinar. We are having a webinar on Thursday, April 2nd at 1 p.m. Central, 2 p.m. Eastern. And that will be looking at identification of potential public health workforce data sets and their utility for future research, and consequences of state remote work, speaking of remote work, policies on rural public health, and looking forward to those two presentations. We also have another webinar series on fiscal austerity, which will be March 10th. legal and ethical dimensions of fiscal austerity. So this is the website where you can sign up for that. And again, if you do have any questions or you want more information about these studies, please visit the website or sign up for the newsletter and or hopefully both. Really appreciate everyone coming. These were fantastic and interesting presentations. I see there were a few questions that kind of rolled in at the 3 o'clock mark. So if we can stay for another minute, but just want to say thank you to everyone for doing this amazing research. It is very, very important. It has huge health implications. All of these, both the recruiting and retention and also the workforce departures, are really, really have huge implications for public health. So thank you everyone for being here today, and hope to see you next time.